Thank you so much. I'm really honored to be able to speak with you today, and I'm sorry that I can't be with you in person. I'm going to talk a little bit about COVID-19 research and how we've been working with many people around the country, including Dr. Mandy Fretz, who you might have heard from in the last hour, on understanding the health impacts of the COVID-19 pandemic, which has, I think at this point, affected all corners of our society and remains a subject of intense research, and we have a lot of unanswered questions. So I've put together some slides to guide the discussion, and I do hope to take questions if you have any, because often our best research ideas really come from our audience. So I do want to hear from you about things that you want answered in COVID-19 research so that we can get on it. So with that, let me get started with some general facts here that I think are familiar to everyone, but can't be understated. The health impact of the COVID-19 pandemic has been staggering. In terms of the number of cases, I looked at the CDC website just a couple days ago, and at that moment, there were over 81 million known cases of SARS-CoV-2 infection in the US. There are coming up on 1 million deaths attributed to COVID-19 in the US, and there is great fear that the longer-term impacts of SARS-CoV-2 infection may lead to disability in the longer term. So these are the numbers that the CDC is providing for cases and deaths. So far, the estimates of how many people might be disabled by prior infection are really to be determined. TBD is what I put there. But I put some estimates in the next column based on other things we know. So some news came out that you might have seen last week that about 60% of the US population had been infected with COVID-19 by February 2022. So that's a lot more than 81 million. If you do the math, that's about 190 million Americans who've had SARS-CoV-2 at this point. And those estimates from last week actually showed that about 75% of kids had evidence of being infected. In terms of deaths, there are almost 1 million deaths that have been directly attributed to COVID-19, but there's also been an observation that there are more deaths in the past 2 years than there usually would have been. Some of those are believed to be due to actual infection with SARS-CoV-2, and others may be related to other pandemic effects, people who couldn't get their medicines, people who couldn't get to the hospital. And so right now the estimate is that there have been about 1.18 million excess deaths during the pandemic period. And in terms of starting to answer this question about longer term disability and how it's going to affect US society, the studies are really out in terms of how many people are going to be affected longer term with symptoms. There are estimates that between 9% and 81% of people have symptoms that last for at least several months after COVID-19. If we take a common estimate, about 30% of cases, that means that if you look at 190 million people who've already had COVID, you take about 1/3 of them, and we have 57 million people who may be struggling with lingering symptoms. So all of this is to say that there are more and more COVID-related health outcomes that we're seeing in the US and globally, and more unanswered questions that we need to tackle with strong research programs in collaboration with the people who are affected, which is really at this moment, all of us to work together. So I think that it's also well known, but important to highlight that the impacts of the COVID-19 pandemic have been much greater in American Indian or Alaskan Native non-Hispanic persons. So this is again data from the CDC, and it just shows the rate of cases, hospitalizations, and deaths due to COVID-19 broken out by racial or ethnic group. And it's comparing the rates in each racial ethnic group to rates among non-Hispanic white individuals. And you see I've highlighted the results for American Indian or Alaskan Natives. And you see that the rate of cases is 1.6 times higher than in non-Hispanic whites. The rates of hospitalization are over 3 times higher, and the rates of death are over 2 times higher. So these disparities are in and of themselves staggering. And we need to understand why they are occurring and how we can stop them. It is challenging to study the health impacts of COVID-19 for a whole set of reasons, including just the urgency of the pandemic. This all started about 2 years ago. Many of our data to date come from studies based on electronic medical records, and this was really, really important. So we took advantage of the fact that many hospitals have electronic medical records, which put the data on patients directly into a computer. And so early on, you can analyze who's getting sick, how they're doing. This has been really powerful, and it's really the basis for a lot of what we know about COVID-19 so far. There are nonetheless issues with this approach that we need to think about. So studies that are based on electronic medical records include people who have electronic medical records. That group is not representative of our entire country. It does not include numbers of people who don't have health insurance, people who don't live near a large medical center that has electronic medical records. It generally doesn't include people who don't seek medical care for their COVID symptoms or for their COVID infection, which may be influenced by the fact that they may need to work nonetheless, or they may not want to interact with the healthcare system. So when we look at these research studies based on electronic medical records, we have to think about the fact that not everybody's in those studies. And the people who aren't in those studies may actually have a higher risk of bad outcomes due to COVID. And this type of problem with a study is what we sometimes call selection bias. Who gets to be in the study? So we need to have research that includes everybody, not just those people who are able to get into the medical centers with electronic medical records, for example. Another issue with this type of research is that many people who end up having a hospitalization for COVID-19 may not have seen a doctor in a very long time for any number of reasons. So when they're first coming to care for COVID-19, they may be diagnosed with new conditions. They may be diagnosed for the first time with diabetes. That doesn't necessarily mean that they didn't have diabetes before their COVID-19. And this is an issue that can create some issues in terms of thinking about what is a risk factor for being hospitalized for COVID-19 versus what is an effect of having had a severe case of COVID-19. And those are quite different issues that we need to understand better. And also, medical records often don't include a lot of the information that we need to understand in terms of trying to modify our risks and in terms of trying to protect ourselves better against COVID-19 and such illnesses. So one thing that they generally don't include very well is medical records don't have good information on smoking. And that problem where we're either missing information or we have the wrong information is what we sometimes call information bias. So we get information that is not correct, which can cause issues. So I'm highlighting this for you, and maybe some of you are thinking, this doesn't sound like such a big deal. Can't we just ask people when they get COVID-19 if they were smokers in the past? People are reliable and they often want to participate in research. So why is this such a problem? And I'll just give you one example to kind of highlight some of the issues that we're facing in terms of COVID-19 research. So in early 2020, when there were so many unanswered questions, it was observed that there were fewer smokers amongst the hospitalized COVID-19 patients. So the people who were being hospitalized for COVID-19, there were just fewer of them were smokers, and people were asking themselves, is smoking somehow protective vis-a-vis COVID-19? This was actually a really big question that people were trying to answer. So how did they get to that answer? I'll give you a hint. It was the wrong answer, but how did they get to that answer? And many people really took it seriously. So in these studies, patients were asked if they smoke cigarettes. So that's the rational thing to do, right? You go in and you're trying to understand the relationship between smoking and COVID-19. People are in there with COVID-19 and you ask them if they smoke cigarettes. So if the person said, yes, I smoke, they were categorized as a smoker for the study. If they said, no, I don't smoke, they were categorized as a non-smoker for the study. Now, here's where we get into a little trouble. If they didn't answer the question, they were categorized as not smoking. Because they didn't smoke, so they were categorized as non-smoking. So in a number of studies, patients who were on ventilators for COVID-19 were systematically treated as non-smokers because they couldn't answer questions. So these individuals were on a breathing machine, could not speak, and so they couldn't answer any questions. So things like this were done. They were just categorized as non-smokers. Those same patients who needed a ventilator for COVID-19 were more likely to die of COVID-19. So a few research studies actually came out with the conclusion, that non-smokers were more likely to die of COVID-19. This was absolutely wrong. So, please don't take away from this that this might be true. It was absolutely wrong. In fact, COVID-19 is much more risky for people who are smoking than people who are not smoking. And yet some errors in how the research were done led to the opposite conclusion. And it actually led to some people buying tobacco products to protect themselves against COVID-19. And that's just the kind of outcome we don't want, where research is supporting the behaviors that are opposite to the healthy behaviors. So what we're trying to do is make sure that we have a strong research platform to get the right answers on COVID-19. And a lot of these studies that are being done are really using very strong data from multiple sources to get us to those right answers. And we're just, today I'm going to talk about this effort in what we call C4R to complement existing resources to really help us get to those right answers. So we think that some of the most important questions around COVID-19, which are very fundamental, are how do pre-existing health conditions before the COVID pandemic affect the risk of severe or prolonged COVID-related illness? So that's really, how does the pre-COVID condition affect the COVID condition? Then we have a question of how do SARS-CoV-2 infection and COVID-19 affect long-term health? So that's how does the COVID affect the post-COVID health? And then more generally, how has the pandemic itself, which changed so many things in our society, affect health-related behaviors and non-COVID health outcomes? So this idea of excess mortality or excess morbidity, more bad things happening because of the context of the COVID-19 pandemic, where people couldn't get their medicine, they couldn't do exercise, they couldn't access their doctor, or what have you. And the C4R resource, which is the collaborative cohort of cohorts for COVID-19 research, is something we've been working on to put together comprehensive pre-COVID measures of health and lifestyle factors, a standardized way of defining how COVID's affected health, long-term follow-up of our participants across multiple health domains, including heart disease, lung disease, diabetes, brain disease like dementia, in the setting of a diverse general population-based cohort that includes people who may not be able to access large hospital systems. So the way we've done this is put together 14 existing cohorts that were following participants over many years to understand heart disease, lung disease, brain disease. So cohort that were already doing the work before the COVID pandemic to understand the health of participants. And an important one I want to highlight is one that Dr. Mandy Fretz discussed with you in the last hour, which is the Strongheart Study, which includes American Indian participants. And so we brought together 8 studies designed primarily to look at heart disease, 4 studies designed primarily to look at lung disease, and 2 studies designed to look primarily at brain disease. We put them all together in order to create a platform to start understanding how COVID-19 might affect these participants during the pandemic and post-pandemic. And the population, because of how it was designed, does have a very large number of people in different racial and ethnic groups. So particularly, I'll call out the American Indian or Alaska Native group, the AIAN. We have almost 3,000 participants who are in our C4R resource from this group. And you see we have very large groups of Black, Hispanic, non-Hispanic, white participants, as well as some Asian, mostly South Asian, and other, which is often multiple racial groups. And these participants are from across the country due to the participation of all these different studies that have sites in different places. And these participants have been in the studies for a very long time, like the Strongheart Study, and they've had lots of tests done on their health before COVID. So we know a lot about their health before this virus entered our lives. We have information on biomarkers, including some genetics. We have information on their sleep patterns, on their neurocognition, so in terms of their ability to participate in the neurocognitive tests, their speed of answering questions. We have information on their heart, including electrocardiograms, EKGs, also even cardiac MRI, which has images of their heart. We have information from CT, that's computed tomography. When you have a CAT scan, we have CAT scans of the lung and of the heart in tens of thousands of the participants. And we have information on physical function before the pandemic. So in terms of their oxygen saturation, in terms of their lung function, their ability to walk. So all of these participants, we understand really well how well or sick they were when we entered the COVID-19 pandemic. And then once the pandemic started, we tried to learn how COVID was affecting their lives and their health. We did that through 2 waves of questionnaires starting in April 2020 and continuing to the present, through understanding who was getting hospitalized for COVID-19, who unfortunately might have died from COVID-19, and looking at their medical records and understanding that experience, and doing a serosurvey for SARS-CoV-2 antibodies. And I'll talk a little bit more about that in detail, but basically we're getting blood samples from people to see if they have antibodies to COVID-19. And we were able to accomplish this work across over 49,000 participants in the past 2 years, which is more than we actually thought would be able to be in our study. So we were really thankful for everybody's participation and willingness to work with us on filling out these questionnaires, allowing us to understand their medical records and participating by giving samples of their blood for antibodies. I've just put in blue some of the numbers that participated at each of these, and the Strongheart Study has been a really important contributor to all of these different elements. And what we found from this data collection is that obviously there are a large number of adverse outcomes across our population with respect to COVID-19, and those are much, much higher in our Strongheart Study participants who are American Indian. So here's in terms of our infections. Across the C4R consortium, 14% of people have been infected, but in the Strongheart Study, it's over 1/3, 33.3%. In terms of C4R, we have about 9% who had a positive test, because some of these cases, they didn't get tested. In the Strongheart Study, it's about 1/4 of participants had a positive test in the data we have to date. So that's 25.5%. In terms of how many of the participants were hospitalized for COVID-19, across C4R, usually it's about 1 in 50 people, 2.3%, who were hospitalized for COVID-19. But in the Strongheart Study, it's 6%. So that's over 1 in 20. So this is a huge difference as well. And then when you look at deaths, very unfortunately, there's a 1% death rate due to COVID-19 that we're observing in C4R compared to a 3% death rate in the Strongheart Study. So this is really quite similar to that table that I showed you a few slides ago with the CDC data, showing that the impact of the COVID-19 pandemic on American Indian communities has been disproportionate compared to the other communities in the United States, which provides a really strong mandate to understand these disparities better so that we can prevent them. We can also look at, as I mentioned, how people's health before the pandemic might affect their rate of having a bad COVID-19 outcome. And this just summarizes for people with different types of diseases at the beginning of the pandemic, what proportion of them were not infected, that's the blue, what proportion had an infection, but it was not requiring hospitalization and not fatal, that's the orange. And then unfortunately on the right, this is the proportion of people who had a hospitalization or a fatality due to their COVID-19 infection. And it's ranked with the comorbidity, the disease that's the highest risk at the top, that's heart failure. You see that of the people with heart failure, they had the highest rate of a hospitalized or fatal infection. That's followed by stroke and transient ischemic attack, or TIA. The next is kind of a grouping of multiple disorders. CHD, that's coronary heart disease. Next, we have COPD, which is disease of the lungs, followed by diabetes, chronic kidney disease, and hypertension. And all of these conditions, anybody with any of these conditions had a higher rate of hospitalized or fatal infection compared to the total average. So this just highlights how the presence of illnesses entering the COVID-19 pandemic really increased your risk of having a bad outcome. This is showing a little bit about what we're seeing in terms of the power of vaccination. So the vaccination efforts have been impressive across the country, particularly in the Strongheart Study. We observe very high rates of vaccination. And we are, of course, very, very thankful that the vaccines seem to be having such a major impact on preventing bad outcomes. So this slide just shows 2 parts. On the left side, we have how vaccines might affect the risk of hospitalization or death due to COVID-19. And the orange shows hospitalized and fatal cases of COVID-19. The blue shows non-hospitalized or non-fatal. And in the unvaccinated persons, you see that the orange section, the section of hospitalized and fatal, is much larger proportion than it is in the breakthrough infections, where a very small number of people who were vaccinated and then infected had a hospitalization or a death. So we see that these vaccines are shrinking the proportion of hospitalizations and fatalities due to COVID-19 infection, which is really the bedrock on which people are promoting the vaccines, and is really bearing out in the data over the long term. This on the right is looking at the risk of non-recovery at 90 days. So I mentioned a bit disability, those people who have symptoms that continue. And so 3 months after their COVID-19 infection, we see that a substantial proportion of these unvaccinated participants still had symptoms that they related to their COVID-19. But amongst the people who had a breakthrough infection who were vaccinated already, that proportion is much smaller. So again, the vaccines seem to have a really strong effect on reducing this risk of longer-term disability. We're not only collecting information, however, on diseases and about COVID-19 infections, because we know that the pandemic has affected so much more than that and is having all sorts of other effects. So we have questions in our questionnaires about COVID-19 infection, but also about behavior, sleep habits, memory loss, depression, anxiety, fatigue, resilience, loneliness, and stress. And we want to ask also about accessibility of healthcare and finances. And we have research programs now to explore how all of these factors may have been altered during the pandemic period and how any of these changes might be associated with better or worse long-term outcomes after a COVID infection. I mentioned I'd tell you a little bit more about the dried blood spots, so I just wanted to show you some pictures. The way that we got blood samples during the COVID-19 pandemic as part of C4R was very different than the usual. We couldn't bring people into our clinics because of the COVID-19 pandemic, pretty obvious. We wanted people to be safe. We wanted people to stay home if they were able to and wanted to. And we also wanted to get some blood material for us to understand which participants had antibodies to COVID-19. So what we did is we built kits, and a picture of the kit is on the top left here. We have an envelope, we have this little card, we have a little gauze here, some Ziplocs. So when you open the kit, what you find is, look over to the right, a little lancet to make a finger prick in your finger. And then so you can drop a little bit of blood onto this very special card, which captures the blood and suspends it so that it can be analyzed. And so the goal was really for participants to give us 5 spots if they could. 1 spot was great, 5 spots was amazing. Then they fold this card back up, put it in the envelope, and send it in to us. And we got all of these envelopes back, and currently we have over 16,000. What we're able to do with that is look at whether people have antibodies to the spike protein of SARS-CoV-2 or the nucleocapsid protein. What's interesting is that the spike protein is generated by being vaccinated or by being infected. So this is an example of the spike protein level, which is on the y-axis, over time in somebody who was vaccinated. So it was pretty low, it was low, it was low, and they were vaccinated. There were still no spike antibodies. And then with the second vaccine, boop, lots of antibodies to COVID-19 spike protein. This is exactly what we want to see. And this person is therefore going to be protected against hospitalization or death or long-term disability due to COVID-19 is our expectation. By comparison, the anti-nucleocapsid antibodies only generated by infections because the vaccines don't spur this type of reaction. So in this same person over time, this person was vaccinated here, but the anti-nucleocapsid level, very low, didn't go up, just tootling along the baseline of 0. So we can use this information to really understand the infection history and the vaccination history of each of our participants. We have seen that some people react very differently to vaccination and to infection. We're trying to investigate why that is, because it might be important to understand who might need to be boosted sooner, who might be more protected than someone else. So this is just showing that amongst vaccinated people, people who are not vaccinated had lower spike antibodies. People who were vaccinated had higher spike antibodies. So, this makes sense, but also we need to understand, are these people on the no vaccine but antibodies present? Are those people actually infected in the past and they didn't know it? Probably. What about the people who are vaccinated who have low antibodies? Did they have trouble mounting an antibody response to their vaccine? It's an important question. So we're looking into that. We're also looking into anti-nucleocapsid, which shows us the history of natural infection. We see actually that many people who didn't think they're infected, this is this group here, infected, no, many of these people do have that evidence of prior infection. We're able to see that between 1% and 6% of people didn't know they'd been infected with SARS-CoV-2, but on our testing, we're able to see that they were because they have this antibody response. In terms of analyzing why some people might have lower or higher levels of anti-COVID antibodies after vaccination, we are doing some work. I just wanted to tell you a few of the preliminary results because they're interesting. People who have higher antibodies after vaccination and therefore probably higher protection, they're generally younger. Women seem to have higher levels, and people who had prior infection with COVID-19 have a much higher level. Those people who have lower antibodies after vaccination seem to be of older age, men, people who smoke cigarettes, and people with diabetes. So we're looking into this further to understand why those people might not mount as many antibodies. They might not get as much protection from their COVID-19 vaccination. So in summary, there are many unanswered questions about the health impacts of COVID-19 and why we observe such dramatic disparities with a particularly high burden in American Indian or Alaskan Native persons. We need a number of different types of research studies to answer these questions, including studies like C4R with diverse populations that combine information on that pre-COVID health and the pandemic era health factors. So our study, the Collaborative Cohort of Cohorts for COVID-19 Research, or C4R, has had the privilege of working with American Indian and Alaskan Native communities participating in the Strongheart Study to study these COVID-related outcomes, and we're working towards answers that will help to reduce the burden of acute as well as long COVID in those communities. And with that, I just want to thank everybody for listening and for inviting me to speak, and I'll stop sharing to take any questions.
Wonderful, thanks. Let's give her a round of applause. Thanks, Dr. Oelsner. We have time for a question from the audience, and I can help convey it into my microphone if needed. I'm not seeing any right now. Lizzie, oh, one hand. Yeah, oh, yes, Ray.
I was curious if there's on the there's a bar graph with 4 things and there's positive. So is that self-report versus like blood spot, or what's the difference between infection and positive?
Could you hear that even?
I heard it was about the antibody responses and how they correlated with self-report of infection, right? Or vaccination. Let me see if I can go back. This one?
No, it's
Earlier.
Infection versus positive.
Infection versus positive.
One
more?
This one? Oh, yeah, okay. Thank you. Sorry, I misunderstood. So what we see here is that, I'm not sure, I didn't hear your full question, but obviously the number with positive tests is lower, both in C4R and in the Strongheart Study. And this is mostly due to people not being able to access testing at the time of infection, particularly in that first wave.
Does that answer? Okay, thank you. Well, perhaps Lizzie could stay on just a few minutes if any folks in Zoom want to ask a question, or I see Marsha O'Leary's at our Zoom computer here. You could write her a question on a sticky note too. But, oh, we do have a question. It's coming in right now. Okay, all right. Dr. Oelsner, I have one more question before we move on. A comment. Okay, it's a comment. There is increasing evidence of previously occurring other types of coronavirus infections that are likely represented in I think Native American response, or the N response shown, excuse me. And she says, just wanted to comment on that. So thanks, Esther.
Absolutely. It's a good point. The anti-nucleocapsid antibodies can have more similarities across different coronaviruses. And so there is a risk that we would find an anti-nucleocapsid response because of somebody being infected with a non-COVID coronavirus. There is an expectation that that will occasionally happen. Nonetheless, so far the data on our assay from the New York State Wadsworth Laboratory is that this is quite specific to COVID-19. So you're absolutely right. It probably does affect our results. And yet we remain relatively confident that some of the, that a large proportion of these are COVID infections that were missed by.
Thank you. Great work. I love your talk. Appreciate it.